All right, Terry, I think that worked. I see the polls as available now.
Oh,
So
good.
I don't want to launch them right now because I don't want the responses just yet. So I'll launch them as we go through. So, thank you.
Perfect. And if you want to go ahead and share the presentation with the,
And thanks for joining, everybody. We will be getting started right around 12:15. Terry, you're muted.
I thought I had it all under control. Thank you so much for joining us today on our first session of the grand rounds on kidney disease. The first session is from order to outcome, building CKD testing into daily practice. The slide that Mary is showing right now is the required accreditation statement and disclosure information. Just to let everyone know, we have no financial disclosures or conflicts of interest related to the materials presented. The CME code and survey link will be provided at the end of the presentation. You'll also receive a copy of the presentation and the instructions for claiming your CME credit via the email that you use to register with. So if y'all would join me in welcoming Mary Wozniak. Mary is a program manager with the National Kidney Foundation of Michigan. She's focused on supporting health systems and health plans to identify kidney disease early and improve outcomes for individuals with kidney disease. With 12 years of experience in public health and community health care, Mary brings a background of clinical quality improvement and program management. Thank you, Mary, for joining us.
Thanks so much for having me. I'm very excited to be here today to talk about not just about kidney disease testing, but really how to implement that within a practice. Again, I work with the National Kidney Foundation of Michigan, and our mission is to prevent kidney disease and to improve the lives of those living with it. And a big part of prevention is also around that early detection, finding it early where it's treatable and able to really slow that progression. So I want to say feel free to chime in with questions throughout. There's no problem with that. We will have a few polls just to make it interactive as we go along. Um, or feel free to pop any messages into the chat too. Terry will be monitoring that as we go along. Our learning objectives today are to describe team-based care approaches for routine chronic kidney disease testing in high-risk populations, using tools in the electronic health record or registries to identify and close testing gaps in your patient population, and aligning workflow improvements with kidney-related quality metrics, and implementing workflow strategies to increase screening rates and improve documentation. So we're going to start with a quick poll. First question is, what are the two recommended tests to diagnose chronic kidney disease? And in my practice, we routinely test patients for CKD if they have diabetes, hypertension, family history of kidney disease, or none of the above. Give it a minute for everyone to chime in. Okay, fantastic. So, just about everyone is familiar with the two tests for chronic kidney disease, the GFR, that's based on the serum creatinine, and the UACR, that stands for urine albumin to creatinine ratio. Together, those two really give us the best picture of kidney health overall. And then almost all of you are routinely testing patients who have diabetes. Many of you are also testing those with hypertension and family history of kidney disease, which is great. So we will be chatting a little more about that as we go on. Hopefully you can see my PowerPoint slides again. Right. So we're going to start with just a brief overview of chronic kidney disease and why early detection is so important. So chronic kidney disease is a public health problem because it's associated with substantial morbidity, impaired quality of life, shortened life expectancy, and excessive healthcare costs. So according to the CDC, there's over 37 million Americans living with chronic kidney disease, which translates to about 1 in 7 adults in the state of Michigan. But unfortunately, the vast majority of it are unaware that they have CKD. And that's really because of the silent progression, especially at the earlier stages. And CKD accounts for over $100 billion in Medicare expenses. And later stages of CKD, especially when you're on dialysis or need a kidney transplant, are the most expensive. It is also the eighth leading cause of death. But in addition to that, chronic kidney disease can really affect your cardiovascular health outcomes as well, which is really the leading cause of death in the United States. So by identifying CKD earlier, this offers us the opportunity to enhance kidney protective care by improving management of modifiable risk factors. So that's things like controlling blood pressure, controlling blood sugar, getting better nutrition, controlling your weight, and stopping smoking. There's also many newer medications now that slow down the progression of chronic kidney disease. And by finding it early, that also encourages appropriate and timely referral to nephrology, so that patients can have an opportunity to receive kidney education, get on those medications to, slow their progression, but also select a treatment modality if needed for end-stage kidney disease. So again, these are the two tests that most of you had already identified. Now, based on risk factors for chronic kidney disease, people who have diabetes, hypertension, cardiovascular disease, and or family history of kidney disease, it really is important that they be screened on an annual basis. I'm not going to go into a ton of depth in this talk about, the guidelines around CKD screening and diagnosis. And that's because at our next session, which hopefully you all can attend in May, that's going to be the main topic there. But I do want to point out the EGFR, it provides insight into the kidney function. So once that drops below 60, that's really when you're approaching stage 3A, and that becomes much more of a concern for your overall health. And the second is the albumin to creatinine ratio, which if there's albumin, that's kind of protein, if that's spilling into the urine, that can be a sign of early kidney damage. So again, I'm not going to spend too much time on here, but just wanted to level set about the two tests for CKD. Because we're going to be talking all about the technology and workflows that can go into supporting better screening for your patients who are at risk of kidney disease. And why is this important? According to the NIH, it takes up to 17 years on average for published evidence to translate into practice. So just because UACR testing is now recommended for people with diabetes and with cardiovascular disease. Doesn't necessarily mean that that's happening across the board. We often find that the urine test is missed. So we're going to talk about some tips on how to really integrate and operationalize this testing in your practice. And I wanted to just do another poll real quick just to see if and how you're currently screening for kidney disease. Just a moment. Okay, so first question, in my practice, we regularly monitor our CKD testing rate. In my practice, we utilize order sets or dot phrases in the electronic health record to streamline CKD ordering. And in my practice, we utilize standing orders for chronic kidney disease testing. Give it just another moment. About half of our respondents have participated. Hey, thanks, everyone. So these are the results. Hopefully you're seeing what I'm seeing. It looks like about 36% said, yes, we do regularly monitor our CKD testing rate. 36% do not. And then a fair number of you is kind of not applicable to your setting or your work. In my practice, we utilize order sets or dot phrases to streamline CKD testing. About 21% said yes, 7% said no. So this is maybe an opportunity for you to consider if that would be a good fit for your practice. And in my practice, we utilize standing orders for CKD testing. So glad to see about 50% of you are utilizing standing orders. That's great. Keep in mind, not all of these things that we're suggesting here are going to work for every setting. We really want you to, consider what works in terms of your staffing, your current workflows, and what's available in your particular EHR to support the screening. We're going to talk through these technologies, processes, and educational materials that can support CKD screening across your different phases of patient care. So from pre-engagement, when the patient may not have an appointment at this time, to the pre-visit planning, that's kind of preparing for the patients coming in the next day or that morning, the rooming phase, and then the visit phase with the provider. And by incorporating team-based care, you can more proactively reach your patients with preventive services such as CKD testing, and integrate these approaches into your existing care processes. So in the pre-engagement phase, the personnel involved in this stage oftentimes are your population health team. The registration and front desk may be the ones reaching out, trying to re-engage patients in care, or you might have a community health worker on the team who's out in the community working to connect people back to the healthcare team. In terms of technology you can use, we'll go through some examples of these, but registries are very nice to identify patients who are in need of screening, and outreach tools, such as through your electronic health record or other ways of reaching your patients to let them know that they are due for testing. Some of the processes that can be used are training personnel to review alerts if you're utilizing alerts in your EMR. Preparing patients for testing, really reminding them that both blood and urine are going to be collected that day, and conducting population health outreach. And then we'll share a couple of the education materials that we have available that you're welcome to adopt. So by focusing on outreach to patients at this pre-engagement phase, you can reach the population even if they aren't being seen soon for care. So what is a registry? Registry has a lot of different features. It's a population health management tool that can really pull in different components or different variables from your electronic health record and display it kind of all together. These can be very useful to manage chronic conditions, monitor preventive services, and drive quality improvement. So key features are going to be the various data elements that you pull in. I'm going to show one example from the Michigan Primary Care Association. Not sure if any of you work right now with like a federally qualified health center, but most of the FQHCs have access to this particular registry. Otherwise, I suggest you look into what types of registries or reports are available through your EHR. You can also kind of customize the date range that you're looking at here. Maybe you want to go back a year, maybe you just want to go back a month. But here they're pulling in like the EGFR and the UACR testing, what the results are through MPCA at least, and they're able to identify the risk level of the patient based kind of on those two tests. So if you wanted to use this to really identify those patients at highest risk who haven't been screened, or maybe you're using it to identify those who just don't have any testing done in those previous 12 months to bring them in for testing. So in this case, MPCA, this is kind of more like the definition of how they pulled these together, but these are patients with an active diagnosis of CKD or diabetes or hypertension, and it does exclude people with end-stage kidney disease. But the nice thing about registries is usually you can kind of customize exactly what you want to see in those. I want to share some campaign messaging that comes from our kidney awareness campaign called Are You the 33%? This campaign really highlights that 1 in 3 Americans are at risk of developing chronic kidney disease and encourages them to take a risk quiz to find out if they are, in fact, at risk of kidney disease. So these are some messages that can be tailored. Some health centers we've worked with will tailor this based on diagnosis codes. So maybe they want to reach out to all their patients who have diabetes or all their patients with hypertension to transmit that message, either via portal. Not sure how many of you are using like text messaging to engage with your patients in that way, but we can support you in developing any particular messaging that you're interested in. This is also just a sample outreach letter that we created together with a health center that we've worked with on some technical assistance. Sorry. So really just letting them know what the tests are that they're due for, why it's important, and how to get connected for care. So next comes the pre-visit phase. So this is really when a patient is scheduled for an appointment, maybe the next day or that morning, and really going through having maybe an MA or nurse or population health team go through and conduct that chart prep, looking for some key elements that maybe the patient may be due for or need to be discussed during that visit. I'm curious, maybe just by like a show of hands, how many people are currently using a chart prep process and or a huddle in the morning to kind of identify those patients who need any particular testing, including CKD testing. Your answer in the chat too. Okay, we're going to talk about it a little more in depth and kind of how you can integrate that. So best practice alerts, a lot of EHRs have this available, or it might look something more like a health maintenance form. But this is just an example shared by Cherry Health of the different preventive services that people are due for. So they have turned on an alert related to kidney health evaluation testing in diabetes, as well as one for, I guess it doesn't show here, but there is also one available for hypertension. And just, kind of a quick way to see what patients may be doing for. Clicking on the shapes provides further detail on the status of each patient's quality measures. We have heard a lot that there's often alert fatigue, though. So if you have multiple, pop-ups coming, especially when the clinician is in the middle of doing other things, sometimes those just get overlooked. So really choosing carefully as to what's going to pop up and what the clinic deems as like the most important ones to keep top of mind. But these alerts can also be used, for example, I'll refer back to MPCA because I'm most familiar with their processes. They have what's called a pre-visit planning tool. So based on those alerts, the pre-visit planning tool will allow them to see for each patient that day, kind of what are the gaps in care. Maybe people need a mammogram and, referral for colon cancer screening and the CKD testing. So those are just some additional options. We do like to point out huddles, particularly morning huddles, is just a great opportunity for the team to quickly come together, review which patients are coming in, and proactively plan out their care, including what testing they might be available for. So there are some examples. I encourage you to check out this website here about healthy huddles happen, and really how to decide as a team, how much time you're going to spend. Usually 5 to 10 minutes tops is sort of best practice. When and where you're going to huddle, the reasons for the huddle, what the main topics are. So it doesn't just have to be testing, but it could be things like patient safety concerns or complaints that you've heard, things like that. Who's going to prepare for it, and then just really, going back to that process and making sure it is working well for the team. And everyone has a chance to chime in and speak up, can really make huddles be most effective. Okay. Next comes the rooming phase. This usually involves a medical assistant or a nurse who's collecting the vitals and kind of going through the health history. This is a great opportunity to check to see if the UACR and EGFR need to be done or have already been done. It sounds like a lot of you are already using standing orders for other staff members to be able to actually like pin those orders and put them into the system so that it doesn't take that extra, click on the provider side to order it. Also a great opportunity to educate patients on the why. Why are these tests needed? Why are you asking for my urine? Sometimes patients will get a little concerned that you might be testing for other things, but assuring them that this is really the best way to see the full picture of their kidney health. Also a good time to check for, health literacy and if there's any concerns or misunderstandings regarding the education. And we'll be getting into some health literacy topics a little later in the conversation. Having education materials ready on hand for the patient is a proactive way to teach them about CKD and its risk factors. So we'll go through a couple of examples that we have available. This is a standing order policy, again, created by MPCA that allows the other team members to go ahead and order, in certain situations, order some specific testing to be done. It really can help with improving patient care, efficiency, and decreasing those missed opportunities. And just keep in mind to implement this, really, it helps to identify that champion, garner support from the whole healthcare team in terms of creating this standing order policy and reassessing to make sure that it is working well for the team. These are some of the education materials I mentioned. The one on the left shares the different ways that kidneys can help keep you healthy. A lot of people aren't really familiar with kidneys apart from the fact that they filter our blood. But they do a lot of other really important things like keeping our minerals in balance, regulating blood pressure, regulating our fluid levels. So definitely important to keep them healthy if we can. And then in the middle is just kind of an overview sheet with some key statistics on chronic kidney disease. And the one on the right really gets into like the risk factors for kidney disease and how to find out more about your risk and talk to your doctor. Okay. And then finally moving into the visit phase, this is really the chance for the provider to go into any more conversation about why the tests are being done. Some of the technology here can be clinical decision support tools, using best practice alerts if that's something your clinic decides, and having order sets that built in for patients with those diabetes, hypertension, those risk factors to be screened just in a more standardized way. So some of the processes are reviewing the previous labs, educating patients on what their numbers mean, and reviewing any pending orders for screening. So the kidney profile, this is kind of another way of saying EGFR plus UACR, the kind of the two tests together. There are a few labs where this is available as an orderable unit. So we're familiar at least with Quest, LabCorp, and Henry Ford in the state of Michigan. There may be others, but those are the ones we're aware of at this point. Um, but many times in your EHR, even if a kidney profile is not available, you can add maybe a custom favorite or add these two tests as a way to order them together. And then also note there there is some confusion sometimes. I just want to point this out around urine albumin creatinine ratio. That is the more updated term for this test, and it does consist of two different CPT codes. I just bring this up because oftentimes, either in the EHR or maybe at the lab, there are different names used for this test, particularly microalbumin. Many of you probably heard that term, which is a little more outdated now. But just to clarify that really this is a test, it's a ratio between the two, the albumin and the creatinine. So making sure that when you're ordering it, it is in fact being processed. And I bring that up because we have discovered, at least at a couple labs, the urine albumin component may be available, but they're not necessarily testing for urine creatinine. So it is something to double check with your laboratory about. And the UACR is a more accurate measure than just measuring the urine albumin alone. Okay, this is one example of an order set that was built by Authority Health, which is a clinic that we conducted some technical assistance with on this. So they've created two different types of order sets in Athena 1. The bottom one is called CKD Initial. That really includes the screening tests. And then CKD Stage 3 gets into a little more of what labs are needed about in order to manage chronic kidney disease, and then also adding in some specific information on nutrition. Any of these order sets, if you're using a best practice alert, they should be tied back to that best practice alert in the EMR to make sure that that's closing that gap. So I wanted to share a clinical decision support tool that oftentimes can be built into an EHR. Takes a little more manipulation with your data team or your HIT team. But this one comes out of the National Kidney Foundation and based on the KDIGO chronic kidney disease treatment guidelines. So really that importance of assessing for any of the conditions that put a person at high risk of CKD, screening for CKD with those two tests, repeating again in 3 months if anything is abnormal. And then if that abnormality remains either a high ACR or a low eGFR, then assigning the GFR category, identifying the cause of CKD, and assigning the albuminuria category. We do have, like a laminated version of this. If you do want any of these items, in person, printed out, we're happy to mail those to you. So please just reach out, and we'll happy to get connected with you. But this information is just used at point of care to help inform decisions about a patient's care in line with the standards of care. Here's a couple more education materials. The one on the left is really a fan favorite that we found with a lot of the clinics because of the visuals that it uses to explain the GFR level. I really like this one about urine albumin. It may be a little small to see, but you see like the red up there represents the blood. We want our protein to stay in the blood. It shouldn't be spilling through into our urine. If you think about like a coffee filter, you don't want holes in your coffee filter or the grounds will spill through. So that's just kind of a nice visual to explain what urine albumin is and the importance of focusing on blood pressure as well. The green document here is all about taking care of your kidneys and highlighting that risk for people who have diabetes, that they should be getting their kidneys checked regularly. And visual aids are oftentimes more effective than written material in improving health literacy. So, we've definitely found that short videos tend to be well digested and more popular these days. So here's a couple of video links just about the basics of kidney disease and what the two tests mean between the GFR and the UACR test result. These can be used, after kind of that initial conversation to reinforce messaging around kidney disease. Okay. I also wanted to mention, quality improvement is not just a kind of a one-time thing where you're going to make one change and be done with it. It's really a continuous process where you're continually looking at these three questions, this model for improvement. And this comes out of this isn't something we created. This is, IHI, the Institute for Healthcare Improvement. The first question you're really asking is, what are we trying to accomplish, or what problem are we trying to overcome? How will we know if that change is an improvement? So really using a data-driven approach to see where are we at now, where do we want to be, and how are we going to measure that? And then deciding after you've sort of analyzed like what the problem is, what the root cause is, what change can we make that might result in an improvement? And taking small, deliberate tests using the Plan, Do, Study, Act PDSA cycle, testing out maybe with like one care team member or a handful of patients to see if that small intervention works well, if it needs to be adapted, if it needs to be changed, and then spreading that further as you show that is successful. Um, I just bring this up. I'm not going to go again into a ton of depth here, but this is something that my team, myself and Terry, we do a lot of support around quality improvement with clinics. If that is something you're interested in connecting with us about, please do send us an email. We would love to chat more with you. We have a lot of tools and resources and like a data analysis plan that we can share with you to get you started. Okay. I also wanted to point out today we focused a lot on integrating technology and workflows and education around CKD testing, but just a reminder that's sort of just the first important step in a whole chain that's going to lead to better outcomes for people with CKD. So testing and then, confirming again in 3 to 6 months, making that diagnosis. We know that if a diagnosis is in the chart, the condition is much more likely to be managed and to be managed well. Treating both related to healthy lifestyles and medication management. And then when appropriate, referring for specialty care with nephrology and just generally tracking how well a patient is doing with their treatment plan and making changes as you go along as needed. So I hope you can give a little thought not only to the tools we talked about for screening, but how those tools might also be utilized at these other stages of care, the care continuum, to help individuals with treating their kidney disease. Okay, I'm going to take a short pause here and just see if there's any questions that have come up or any reactions. Right. Well, we've got one more poll to go. Great. So in my practice, in my practice, we regularly screen patients for their health literacy level. And how often do you use the teach back method? Give it just another moment. We've got about half of the folks chiming in so far. We appreciate your responses. It does make it a little more interactive and helps us to kind of understand where your different teams are at. So just about all the clinics, or all the folks on the call are regularly screening patients for health literacy, which is fantastic. And many of you are using the teach back method, either daily or weekly. And just 8% rarely. So this will hopefully just be a little bit of a gentle reminder about the importance of these topics. So we're going to touch now on effective patient engagement. An important part of this effort, of course, is health literacy, which empowers patients to make informed decisions about their care. It involves navigation, trust, access, and decision-making. Health literacy can be viewed at two levels. So personal refers to an individual's ability to find, understand, and use information to make health-related decisions. And organizational reflects how well the organization equitably enables individuals to find, understand, and use information and access services. So I'd love to hear if anyone wants to unmute if you do find that an individual has challenges around health literacy, what are some of the ways that you approach that to make it more accessible for them? Got any brave volunteers? Sounds like many of you are using Teachback to make sure that what you're saying is being understood. We know that 9 out of 10 Americans unfortunately do not fully understand or fully remember what to do after their visit with their doctor. So really, it can be very helpful for patients to recall information expressed in their own words. And Teachback is one of the great ways to do this. It's an evidence-based intervention that enhances the patient understanding, their engagement, and the likelihood of adhering to the treatment plan. So some examples of Teachback starters are just to be safe. I want to make sure we're on the same page. Can you tell me how you're going to take your medication? Or I want to make sure that I explain things clearly. So again, kind of putting the onus a little bit on yourself to have explained things clearly and then having the patient repeat that back in their own words. And then if the patient doesn't teach back correctly, or maybe they're missing something key, is really trying to reteach that concept using different words. And sticking to like chunking the information, sticking to maybe 2 to 3 main points that you want to drive home. It's really important to ask these questions without any shame or pressure and create a comfortable environment for understanding. We know that at least initially, as you get used to using Teachback, it can take a little longer as you adopt this into part of your standard workflow. But ultimately, the misunderstandings that it can make up for, it saves substantial time later on and helps, reduce risk too by the patient being more involved and invested in their care. Just a few other points about how to empower patients using health literacy. Teaching and normalizing that patients can ask questions when things are not clear. Explaining the information in plain language, of course. We found a lot of folks like to use analogies or audios, maybe pictographs to actually draw out, because everyone has a different learning style as well. Some people do better with visual. And one analogy that we found when it comes to talking about chronic kidney disease is thinking of it as like a train on a track. So if it's hurling down the track, you can't really go backwards per se, but you can slow down that speed of progression towards kidney failure. Also highlighting trusted resources and where to find reliable health information. Certainly, if you want to refer patients to our website for some initial information on chronic kidney disease, it's kind of a great starting point, at least, and it is available in English and Spanish and Arabic. And then inviting note-taking or symptom tracking or having people come, even with questions in hand that they want to make sure get addressed at that visit. And then just encouraging growth and comfort within the healthcare system. This might mean having some of the staff take a little extra time to explain how to utilize the patient portal, for example, as a great way for patients to be engaged in their care, understand where to find, their health record and their lab data. And just empowering patients as team members and active members in their care is so important. It makes them feel like they matter, and it makes them more invested in their own care. And then I could chime in. I would love to hear what are some effective ways that you found to engage patients while teaching health information. Any examples you'd like to share? I get it. Many of you are probably trying to eat some lunch right now, so no worries. Wanted to share some kidney specific language to keep things in, plain language. These are some terms that might throw some people off. Chronic. So really explaining that this is a longer term kidney problem. It's not something that's going to go away. It's happening over time. Kidney disease nephropathy is one that we hear a lot that patients don't always know what that means. So that your kidneys are not working or not filtering the blood like they should. Um, they may not be familiar with what a nephrologist is, so really explaining to them that that's a kidney doctor or kidney specialist. And albuminuria means that we find some protein in your urine. End-stage kidney disease, you can talk about your kidneys failing or that they stop working and that you have different options to treat that. And I think also importantly is to keep in mind that person first language. They're person first before they're a patient. So really referring to people instead of saying kidney patient, a person who's living with kidney disease or who's dealing with kidney disease.
Mary, we have a comment in the chat. Donna said before she educates the patient, she asks, can you explain your process the way you do it now? And then
Fantastic.
she uses that information to guide the education session.
Yeah, I love that. Especially when it comes to taking medication, right? Instead of saying, are you taking your medication? Like a yes or no, like how are you doing that? Then to be able to identify if maybe there's some gaps or times that they miss the medication or that they have concerns that might not otherwise come up, right, about side effects and things. Thank you for sharing that, Donna. Wow. Donna, I'm sorry, I'm not sure if I'm pronouncing that right. The language we use is key. Yeah, absolutely agree.
I didn't want to interrupt, but it would be, just across the healthcare continuum, not even just with kidney disease, but if we all somehow could use the same language with our patients, and at some point in the future, that would be great because how I explain something might be different than the way you explain it, Mary. So um, but communication also is key, like listening to the patient and understanding where they're at and meeting them where they're at. Because previously, like you said, are we using the literacy assessment?
Mhm.
Unfortunately, prior to taking this position, there are a lot of patients that still cannot read, or if English is not their first language. And then we give them a lot of materials to go home with, and we feel like we can check the box and say, oh, yes, I gave Mr. Smith all the information he needs. But if he doesn't know how to read or utilize that information, then we really haven't done our job. So the box might be checked, but still the patient is not educated. So there's still work, obviously, that needs to be done. But yeah, so that's just a comment. Thank you.
100% agree. Thank you so much for that. Appreciate it. And it's so important to, like you said, meet people where they are and personalize it to what makes sense to them, right? People may use different terms for different things. And I think listening for that, like maybe someone's talking about their sugars as opposed to, so using the word sugar instead of glucose or things like that, diabetes, is also important to kind of put it in the words that they're using too. Thank you so much. Okay, just sharing a couple of toolkits that may be useful as you're thinking about integrating chronic kidney disease, standardization or workflows. This Managing Chronic Kidney Disease Resources for Rural Providers was created together between the Michigan Center for Rural Health and the NKFM, based on our work with several rural health clinics. There's a lot of great materials in here, a lot of resources. I also want to point out there's some like sample policies and procedures that can be adopted or adapted by your organization to support kidney disease screening. And then if any of you are working with health centers that are part of the MPCA, I strongly recommend checking out this playbook that they've created as well. It's useful not only to understand like the specific population health tools that they've developed through Azara, but also to kind of just understand what are the educational materials available, how are other clinics working to address chronic kidney disease, and just a lot of great tips and tricks in there. Um, okay, so we're getting to the end. I just wanted to summarize some of the key points, and then we have some discussion questions. So very important to identify, um, engage, and empower your patients in chronic kidney disease testing. So using technology and streamlining processes to recognize and reach patients in need of care, and using technology to build communication channels that promote adherence, feedback, and shared decision making. And also equipping your patients through health literacy to take a more active role in managing their kidney health. I would love to hear from you all. Based on today's discussion, are there any technology or workflow changes that you'd like to consider taking back to your particular practice? Again, it sounds like many of you are already using things like standing orders and order sets and huddles. Is there anything that jumped out at you as an idea you'd like to try out? Okay, thanks for your response, Pam. You'll be digging through the resources we pointed out today. Yep. And we're always happy to have like a follow-up call with you. Just please feel free to reach out, and we're happy to discuss any of the barriers you're finding too. And then I'd love to hear if any of you are doing, education with patients around CKD testing. How do you talk about it? How do you explain what those test results mean? Um, I've heard oftentimes CKD might not really be talked about until it's in a little bit of a more advanced stage, like a 3A, 3B, when it might be having more of an impact on people's health. But particularly at those early stages, are there any particular messages you would want to share? Oh, I saw something in the chat. Are they billing or third party? Martha, I'm not sure I understood your question. If you
So
want to unmute.
normally, from what I've understood, and you guys can correct me if I'm wrong or not, but it's not the providers that are billing, it's a third party. So a biller coder. So I feel like if we hear silence, it might be for that reason. So I just thought I would bring it up. I just didn't want to, yeah, say it out
Yeah,
loud.
that's fair. Yeah, a lot of times that diagnosis is happening based on what's being written in the chart, but then translated into coding.
Yes.
Yeah,
Mary, this is Donna. Could I ask just a random question?
sure.
Um, did did you or did the numbers support that during COVID or after COVID, maybe um, there was a spike in the CKD diagnosis or at later stages because maybe people were lost to follow up. I had a particular case yesterday. I was working with a gentleman, um, and I have to dig through the chart a little bit more, but I'm just like I was actually sick to see his his EGFR and all like nothing was done for this man for a long time. And I just was wondering if it was a COVID thing or if you saw numbers spike during that time.
I'm sorry to hear that. I will say that certainly acute kidney injuries became um, more likely for people who had COVID infection. And acute kidney injury can lead to chronic kidney disease, but not always. Right. So that definitely is associated. Whether or not we saw like a spike, I will say what we did see looking at the data from Medicaid that we were able to see during that time period is that testing rates went down a bit. And they have recovered since then. And in 2022, they pretty much recovered to baseline. I don't have data right now beyond 2022 for that cohort, though, in Michigan. But what
I,
you're saying is that just it seems like he was disengaged from care, or
yes.
maybe the care that he was receiving, he wasn't receiving treatment specific to his CKD. And unfortunately, we see that all too often that,
Oh, okay.
other diseases kind of take precedence, especially if they're, a little more, they're seen as more urgent maybe than kidney disease because it
Hmm.
might be seen as like a down the road kind of issue that doesn't need to be
Right.
addressed. way,
Right. So it wasn't that
unfortunately.
he had no, he didn't have, say, COVID himself, but I'm just saying that time frame, was because like you said, that COVID kind of was precedent at that time. So maybe some of the other things kind of took a, was on the um back burner a little
A
bit.
back
But
burner.
yeah,
Yeah.
okay, thank you.
Yeah, it's unfortunate. Thanks for sharing that. Right. This is well, Terry, I'll let you talk about this part.
All right, so this is it's called the AIP form. You will receive this when I send out the slide deck. Please follow the directions on it. There is also at the bottom of there, if you run into any problems with this, contact MSU. Um, I don't have access to the system or the platform, but they'll be able to help you if you run into issues. One thing I do want to say is make sure that you have enabled your pop-ups and that after 30 days, the credit can't be claimed anymore. One other just quick caveat with this is that in about a month from now, you'll receive another survey from me. It's just kind of the follow-up. If you could take a few minutes to fill that out, it's just helpful for us to continue to do this and do it better and use the suggestions that anyone gives us to improve what we're educating people on.
Absolutely.
So I thank Mary so much for the great information. There's not a lot of these around that kind of tie into diagnosing and the diagnoses and things like that. So I want to thank Mary, and I thank all of you for participating also. So Mary, if you want to just see if they have any questions.
Sure. Yeah, let me just check. I saw there were a couple more things in the chat. I then use that information to guide my education. Oh, sorry. That was older. Thanks so much. I did also just want to point out the upcoming sessions. If you haven't had a chance to register for them, you can kind of register for these individually through the QR code there or via the NKFM website under healthcare professionals. So hope you can attend some future events too. And we really appreciate you taking time out of your day for this.
Thank you, Donna. Well, since we have finished up a little early, we'll give you 10 minutes back to your day. Look for the email today. It will come out. It will come from Terry Walters at nkfm.org. Like I said, it'll have the CME information on there and the slide deck for you. If you have any questions or if you are requesting any information or anything, Mary's information is on there. My information is on there. Feel free to reach out. We will help in any way that we can.
Thank you so much, everyone.
Thank you, and I hope to see you next month. Have a good day.